Good afternoon. Please join us and welcome to our first meeting of the Budget Subcommittee on Health and Human Services. I want to start by thanking my colleague, Mr. Jones, for being here.
You're welcome.
Because were it not for that, you'd be looking at just me up here. So thank you, sir, for being here. It's an honor. We're going to dispense with calling the roll and ask those who are going to be presenting first to prepare to come forward and just give us a high-level overview that we have prepared for today. I want to say how thankful I am to Mr. Jones and the members of this committee for the work that we did last year. We did things that were critically important to Californians in every sector of health and every sector of human services. And we'll get into that at a future meeting when we can actually share that with all the members and all of our colleagues. But I appreciate you, sir, and I appreciate our members. I appreciate our staff of this committee, and I appreciate all of the department representatives, the LAO, and all of the advocates who've made this an important year. For me, I came here, I am a social worker by training. I came here recognizing that for many years prior to my arrival, our economy was such that programs in the areas of health and human services were merely just cut and cut and cut and cut. I am honored that we are here at a time when we can restore the ability to provide quality services to people in a responsible fiscal way, but to make sure that individuals who are served by our MCO tax or by our developmental disabilities bill can have all of the services that they can. So it's an honor for us to re-engage in the conversation in health and human services, and looking forward to a banner year. With that, I'll yield to my colleague and see if Mr. Jones would like to have any opening remarks. Thank you. Always brief and to the point. Thank you, sir. With that, we're going to start with our first panel. And if I could invite Ms. Kent and her team to come forward. Welcome.
Thank you.
We know that you probably missed us, and here we are again, ready for our marathon hearings. We look forward to what you have prepared for us today. Welcome, Ms. Kent.
Great. So I just want to say thank you, and looking forward to working with you as well. Jennifer Kent, Director for the Department of Healthcare Services, and with me is Mary Cantwell, who's our Chief Deputy and State Medicaid Director. As you know, we have a fairly significant department. We have a fairly significant budget. We oversee many critical both financing and programmatic policies and areas of importance to you and the populations that we serve. The biggest, obviously, the program that most people think about when they think about our department is the Medi-Cal program, and right now we're standing at a membership count of approximately 13 million and more, growing every day. I think that speaks to both the commitment that the state made to expand coverage to individuals with the Affordable Care Act, and so we've seen obviously significant enrollment and expansion of coverage to individuals since January of 2014. And Mary, as part of her presentation today, will be talking about what those numbers have actually looked like since the enrollment started. But with 13 plus million people under care with us in the Medi-Cal program. We're really running two programs that people don't always think about. So we have both a managed care program as well as a fee-for-service program. There's approximately 10.5 to 11 million people in managed care, and there's 2.5 million or so in fee-for-service. The individuals that are in managed care are with our 22 contracting health plans throughout the state. All 58 counties have managed care available to those beneficiaries. The beneficiaries that are in fee-for-service are primarily individuals without either full scope benefits. They could be dual eligibles, meaning we're providing care to them on their Medicaid benefits, but they have Medicare as a secondary or as a primary payer. There may be individuals without satisfactory documentation status composed in that 2.5 million. There's small residual populations in Medi-Cal, such as foster care and others, that are not mandatorily enrolled in managed care. And so when we talk about the department and the program, we, in our mind, think about the two different sides. But, it's always good to just remind people that when we talk about either rates or plans, that not everybody sits in both of those. Apart from the significance of our budget, we're a department of approximately 3,700 staff, and that's about $600 million in state admin dollars that we spend annually to support that workforce. Obviously, one of the significant issues that, and I think there was a hearing earlier today that my other Chief Deputy, Karen Johnson, testified at on some workforce issues that we have. We're engaged in a wellness and workforce development program that's a part of joint with the Department of Public Health and Kaiser, as well as SEIU 1000. When you have significant, important, and really complicated programs, what we invest in our staff is of great importance to us, because those are the individuals that will be doing these jobs long after we are not here. And we care about the department and we care about the program, so we really want both well-trained and professionalized workforce, but we also want them to be happy and healthy in the profession and career that they've chosen. I think you will hear about this in coming committee hearings as well. We absorbed two departments back in 2013, the alcohol and drug programs, as well as the community health, or the community portion of the Department of Mental Health. That is an ongoing series of really exciting areas that our department is undertaking with our Medi-Cal program in terms of the closer integration and alignment of behavioral health issues with physical health issues. And so more on that as we talk about waiver and other items before this committee. But I think that what you will see consistently in a lot of the programs that we are working on, both from, stemming from legislative activities as well as initiatives with the federal government, is we're really looking at these populations that are high cost, high utilizing. They may be fragmented across various payer sources, and they are complicated, and they may have behavioral health issues, they may have substance use disorders, they may have a lot of complex medical conditions, and ultimately what that means is their health is not as good as it should be, and also they are costing the system an extraordinary amount. And so a lot of the initiatives that we're continuing to work on this year are looking at those high-cost populations and trying to both improve the quality of their health care and their life overall, as well as lower costs in the overall system. One of the key things that I wanted to just draw quick attention to that you will again be hearing about at a later committee date is some of these transitions in populations. I know we'll be talking about the AB 75 transition later on today, but there's another transition of children that we will be working with the legislature and stakeholders on, and it's looking at children in our California Children's Services Program in terms of CCS. We have children that today may be in CCS for their CCS condition, which could be something as severe as cancer, cystic fibrosis, hemophilia, a genetic disorder. So the CCS program pays for those CCS conditions. Their other conditions are paid for by typically a Medi-Cal managed care plan if they're in a Medi-Cal managed care plan. If they have a developmental disability, they may be seen in a regional center for their regional center needs. So you have children that are literally being seen across 3 different payer sources, and sometimes the line is not so clear as to who should be paying for what, and that leads to a lot of both lack of coordination as well as a lot of burden on the family to try to be the coordinating entity. And so we have a proposal that we're working on and that we will be working with you on as well to do a better alignment of care coordination with those very, very fragile children. So with that, I'm happy to take questions, but really excited to be here and welcome the dialogue that we have.
I would ask just one question about the last item you mentioned, the CCS transition, and the reason that you gave made sense to me, that if there are as many as 3 systems to make it easier for the consumer to access a system. That made sense. I wanted to ask you, though, about what might be lost. And, I have heard from providers and family members who have expressed concern that what would be lost is continuity with a provider who has served that child for many, many years, and that was a concern. And so initially I had the question, well, why are we doing this? And you explained it. But it does seem to me that we're losing out on continuity with the provider, and given that these children have the very severe health needs that you described, it seemed to me that we have to figure out a way to keep that. Can you speak to that, please? Thank you.
Sure. So taking just a quick step back, and obviously this isn't a hearing on CCS, but it is one of the things that we are working on this year as an initiative. It's the oldest program in our department, so started in 1927. So around that program has really grown up a specialty network of providers and hospitals and other types of ancillary care that is a true standout example that doesn't exist in other states. And obviously we have created a center of excellence that not only takes care of kids within the CCS program, but children of any, children in private coverage, children from other states come. Obviously we have children's hospitals and others that are magnets for other areas of states that don't have that kind of expertise. When we started talking about changes to the CCS system, one of the things that we heard right off the bat was, well, I want to be able to stay with my provider. We have quality standards that we administer through our department. So in order to be a CCS paneled provider, there are certain quality requirements that you have to demonstrate to us in order to be paneled with us. We are not changing any of the CCS paneling, and in the small areas and plans that we have said this is where we're interested in having these children get their care coordination. The plans, their county organized health systems have been told you have to contract with and use CCS providers for children with CCS conditions, and so that's one of the requirements. There's also continuity of care requirements that we have in place that are standing with any transition that we do, which is if a child is transitioned into the managed care system, and the provider, for whatever reason, is not contracting with the plan still has to pay that provider for at least a year while that child is either going to stay with that provider and the provider is going to go under contract with the plan, or making sure that there's another CCS provider that can take care of the child. So I think, more on this, but we both acknowledge the concerns, but we think that we have mechanisms in place as part of our proposal to both address that and ensure that children do not have an abrupt either transition or lose their provider altogether.
I'll have some other questions when we get to the hearing, and I appreciate the description. I would encourage that you and your team work with the family to get their input about the transition and to share with them what you're sharing. My guess is that it's like it always is. You make a great plan, but implementing it, there'll be things that will come up that cannot be foreseen that might cause a gap in continuity of access to a preferred provider. And, so I think it'll be important for us to use our ramp-up time to help iron out those kinds of bugs in the system. And by doing so, by engaging the families in the conversation, it might reduce their anxiety. Maybe it won't. And I know that they're all going to be here for the hearing because the word is out. And somehow our advocates know better what we're doing on the agenda than I do. They come to my office and they tell me, you're meeting on this tomorrow. So, so I say that to say that they let us know that they're going to be here. And so let us take advantage of the time that we have to really work with them to help prepare them for the transition. Because I'll just say, as someone who recently has lost his primary care physician, he got promoted, and I'm very happy for him. But I'm thrust into a system and a network where I don't know anyone else. And I've been bounced around in a way that I would find unacceptable if I had a child with a severe illness. Really, no one should be bounced around in the way that I have been. But I'm extra sensitive to the children in the CCS program. Because the overlap aside, it's one of the programs that I've been very proud of to hear about in the state of California. And I rarely hear about what people love in the state of California. And so if it ain't broke, I don't want to fix it. If there's some tweaks, then let's tweak it. But let's make sure that the outcome means that the amount of care and comfort that the patients have is not minimized in any way.
Agreed, and we look forward to the conversation. It's been going on for a while, and it'll continue, and so we are excited to have that with you as well.
Appreciate it. Thank you.